This is new to me too, so it's just it's all good.
I'm just trying to close everything because I've got all the articles up here, so I'm just trying to close all them.
Yeah, I was overcompensating with the articles, I think.
Swap share. Maybe I'm on the wrong view mode or something. Swap shared screen with video.
Yep.
Yeah, okay, I can see it now.
Okay, brilliant. Yeah. Okay. So really the aim of the workshop is to share with you what I mostly do with my clients in a bit of and have a session structure, but at the same time talk about more of a mindfulness-based approach to exposure and response prevention, and looking at firstly looking at the research into that and how we've kind of come to that understanding and adding those skills, and then how we can incorporate that. So today's really going to be a bit more, I guess, theoretical, and we'll spend a lot of time talking about the assessment side of things too, and then the rest of it will be quite practical and experiential, and I'll be emailing through like we did this week, the content in order for you to then have access to, and we can follow through as we go along. Yeah. One thing that I did want to mention before we get going is everything will be recorded, so you can have access to it later for you to watch back through as well. So that's all good. But at the same time, I wanted to quickly let you guys know that on Thursday the 21st, I totally forgot that I have Harry Potter booked in. I booked it in like 6 months ago, and it runs over 2 nights. So that day I'll likely be on a little bit earlier, but I'll email everyone the time. And what we'll do is the following week I'll leave a good chunk of time for questions. So when you're watching it back, if you're at work or you can't get to it live, I'll leave time for questions. So if you have any questions regarding that content, then we can do it that way. Is that okay with everybody?
Of course.
Yeah. Okay, cool. So the first thing I want to do is just set the scene and share a bit of a YouTube clip with you in terms of what it's actually like for someone with OCD. And I've chosen this one because I've often said to my clients, you know, there's a bit of a dual process that goes on. It's like, you know, they've got their everyday processing going on, and then there's OCD in the background. So it's almost like there's this constant chatter of OCD compulsions, instructions and whatnot, trying to intervene with the person's day-to-day functioning. And it can be quite exhausting, and clients will often talk about that process of those two things going on. So they're never really fully present in what they're doing. And one of those things is compromised. And I think this video does is a really neat way of kind of demonstrating that dual process, where it shows a young woman kind of going about her day, but then there's this background dialogue, and it's we'll have a debrief about it after I show it to you, but it's a really neat way of kind of showing that process. Hopefully it will play and it will be fine. Here we go. Can you all hear that okay?
Yeah.
One, two, three, four. 1, 2, 3. It's all going to be fine. 1, 2, 3. Everything's going to go well. 1, 2, 3, 4. It's all going to be okay. 7, 8. 5, 6, going to go well. 5, 6, 7. Everything's fine. There's always a gap between the definition of a mental illness and what somebody actually experiences. 8. From my own experience, obsessive-compulsive disorder in particular is an abstract concept. It's difficult to describe to somebody who's never experienced it. 1, 2, 3, 4. The way I see it, anxiety and OCD go hand in hand. 5, 6, 7. Anxiety is the actual worries in somebody's head, while OCD is a person's way of directing those worries into something they can control. To go well. 4, 5, 6, 7, 8. The compulsions of OCD are easy to define and measure. 1, 2, 3, 4. You can count how many times you wash your hands. You can see the chapped skin. You can see somebody turning on and off a light switch. It's going to go well. 5, 6, 7. Because of this, people tend to think of the compulsions when they think of OCD. You're okay. The compulsions are what get portrayed in the media. Don't have to worry. But in my own opinion, it's the obsessions that are harder to deal with. I'm going to be okay. Constantly in my head, I have my own dialogue of OCD running parallel to my conscious thought. This dialogue consists of counting, of repetitive phrases, of grouping things around the room. 1, 2, 4, 5. This dialogue is distracting. It's relentless. It's really exhausting. 1, 2, 3, 4, 5, 6, 7, 8. Going to go 5, 6, 7, 8. At its worst, I estimate that the cumulative time taken up of my day by my OCD was about 4 hours. 7. It's all going to be okay. 1, 2, 5, 6, 7, 8. 1, 2, 6, 7, 8. Everything's fine. 1, 2, you're okay. 1, 2, 3, 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, 5, 6, 7, 5, 6, 7. It's all going to be okay. 3, 5, 6, 7, 1, 2, everything's going 5. Lately, I've been trying to be more open about my experience with mental illness. 5, 6, 7, 7, 8. You're not gonna mess up. 5, 6, 7, I can only speak from my own experience. 1, 2, but I hope that by doing so, I can help to spread awareness and erase some of the stigma surrounding mental illness, and particularly OCD. 6, 7, 1, 2, 3, 4, 5, 6, 7, 5, 6, 7. It's all going to be fine. 1, 2, 6, everything's going to go well. 3, 4, 3, 4. It's all going to be okay. 1, 2, 7, 4. It's going to go well. 2, 6, 7, 5, 6, 7, 8. Everything's fine.
And we're live. Our guest today is a student sharing her story on living with obsessive compulsive disorder.
Okay, what did you guys think of that?
Bit overwhelming, isn't it? That background dialogue the whole time. It's hard to actually concentrate on one thing.
Absolutely. Yeah.
It was even hard to understand what her story, she's telling her story, but then at the same time you hear the OCD talking in the background. So as she said, it is very distracting. It really takes away from, so it's like two activities going on in parallel, and it's hard to imagine.
Yeah. And it's quite distressing too. Like when you hear it for the first time and you don't experience something like that, then having to deal with that all the time can create just a really intense level of distress. Yeah.
I definitely found myself attending to the counting, and the longer it went on, actually finding it quite stressful. And I can only imagine the threat that feels like for the person as well.
Absolutely, because what happens is we then start to focus on that, and this pressure builds up, and this sense of urgency too. Like it's absolutely really intense. Yeah. Any other reflections?
I just thought in terms of functioning, how can you actually, I thought it was amazing what she was doing, considering there was, she was constantly sustaining that reassurance. She was still outwardly doing what she had to do. And so, that's...
Absolutely. And a lot of clients with OCD will be like a duck on water, very like functioning outwardly, but inwardly will have all of these processes going on, and they're able to hold down a job and do all the rest of it, but there's all this other stuff going on, and it's so easy to hide. And it can sometimes even go years without being diagnosed, not diagnosed, but treated. And most of the time when clients will come to you, they're like, so I think I've got OCD, and then when they talk about it and it's been a few years that they've had it, absolutely, it's well and truly, ticks all the boxes and then some. But, to the next person, they just seem like a normal functioning member of society. So, yeah. Okay, so I guess that kind of sets the scene a little bit of what clients will go through. And as you could see, she was experiencing obsessions and compulsions, in a sense, where experiencing a set of intrusive thoughts that were unwanted, but also was reacting to those. And a lot of the time, they're not always repetitive behaviours. A lot of the time, clients will have mental compulsions, and they can look like a whole host of different things, and we'll go through them a bit later. But they're the two primary features. The other thing, and one thing to hold in mind when you're especially doing assessment, is to really decipher if those obsessions are ego-syntonic, so consistent with values and beliefs, or ego-dystonic, inconsistent. And the one thing that remains constant with OCD is that the thoughts are ego-dystonic, so inconsistent with values and beliefs. And that will help with differential diagnoses. Okay. So if we have a look in the DSM, then it will define obsessions as recurrent and persistent, and the person will try to ignore them or suppress them, or neutralize them in some kind of way, because they find them distressing. And then compulsions are repetitive behaviours, but also thoughts that can happen. And basically they're happening in response to the obsessions. And they're performed to reduce distress and discomfort. The other thing that we need to consider is that they have to take up at least more than an hour a day. They need to be causing distress. And also functional impairment. So level of distress and functional impairment are the other things that we need to look at too, in terms of, how much is this impacting on the person's life? How much time is it taking up? And so on and so forth.
So when you're thinking about, say, mental acts or thoughts that act as compulsions,
yeah,
how do you sort of assess if that's taking up more than an hour a day?
Good question. It's a lot of it's self-report.
Yeah.
And clients will, through that discussion, will say, I feel like it's happening all the time, or they'll say things like, I guess it kind of takes up a good chunk. So it's a bit of an estimated guess, like an educated guess, I get, in terms of how long that's taking.
On that note as well, would people meet criteria? I've only had a couple of clients with OCD, but certainly one of them, the thing that they would take up more than an hour a day, but only in stressful periods and when they were not busy. So they essentially were always keeping themselves busy.
Yep.
And they didn't really have the compulsions, and I couldn't necessarily get the thoughts. And my feeling was because they were busy.
Yep.
So they didn't technically meet the criteria, but any comments on that?
Yeah. In those sorts of instances, I'd go with obsessive compulsive traits. And exacerbated by stress, perhaps.
Okay.
And in terms of treatment, I'd still follow the treatment, but I wouldn't perhaps so much focus on the exposure part. I mean, you would, but it wouldn't be as intense. So you might focus on, building a toolbox, which we'll go through as well, and get them to focus on, stress management and that sort of stuff to kind of keep it at bay. So it becomes more of that preventative approach, as opposed to more of a intense treatment approach. Does that make sense?
Yeah.
Yeah. The other thing too, when that happens, clients can sometimes be compulsive but not be aware of it, if that makes sense. as you're going along, they might actually start to realize, oh, I didn't think that was a compulsion, or I didn't know that might, and so you might find that actually even when they're not stressed, they're still compulsing.
That was definitely my feeling with this client. All the beans were ordered and stuff like that, and she was like, "Oh, I'm clean," and I couldn't really ever gauge how much that was happening because it's just part of life.
Yeah.
But yeah.
Yeah. So there are things to keep in mind. The other thing is, for me, I always conceptualize avoidance as a compulsion too. However that looks, whether it's keeping busy or whatever else it might be, where it seems like it's functional, but really the aim of it is to avoid feeling the distress that's going on. So anything that the person does to avoid the distress that they're feeling, I generally lump in that category. So it might not meet the, I guess, textbook definition, if that makes sense. Because I sit in the camp of it being a distress, and we'll talk about it, a distress tolerance, a reaction to distress tolerance or intolerance. So whatever the person's doing to help tolerate distress, but it's unhelpful and not practical in the long run, then you go with, I lump it in the compulsion category, if that makes sense.
Yeah.
Yeah. Any other questions or comments about that? No? I'll quickly say hello, Alina.
Hello. Hi.
Okay. Oop, click back. All right. So the gold standard for OCD is a mixture of medication and exposure and response prevention. Medication for mild, moderate to severe cases, and for mild cases, therapy alone can be just as effective. And you'll notice that with clients, they'll need higher than normal doses of SSRIs prescribed. And for some people, they might have a mild dose of antipsychotic also prescribed to help augment the SSRI if they're not getting that desired therapeutic response. And when the client is on the right kind of combination of medication, they'll often say to you, I still get the thoughts, but they're fleeting, or I'll still get the thoughts, but I feel like the volume's been dialed down on the thoughts. And that then allows them to do the rest of the work from a therapeutic perspective. And we hope that the medication acts as scaffolding to allow the client to have that leg up to help climb over the wall, as opposed to doing it without any of that support at all. So for some clients, it can be very helpful with treatment. For clients that aren't on any meds at all, I often say to them, let's just give this a go first, see how you go, see how you tolerate it. And if, we're not achieving any change at all in the next couple of months, then we might have to consider a referral to a psychiatrist, to consider medication, and so on and so forth. So that's how that kind of works out.
Celine, I missed what you said, sometimes gets added to SSRIs.
Yeah. A mild dose antipsychotic. Yeah.
Celine, at a later date, would you happen to have some psychiatrists that you recommend as well?
Yeah, I can send you guys a list of that. I'll make a note.
Thanks.
I'll just grab it. And I don't forget, I have the memory of a goldfish. Okay. All right. Okay, I think we kind of covered some of that. UBS, so deep brain stimulation, is being used for treatment-resistant clients. It's only for the last 5 or 6 years or so. Basically what they're doing is it's very similar to what they do for people with Parkinson's disease. So they insert an electrode, so the patient's awake during the surgery, and they insert an electrode into the specific parts. There's a couple of locations. I forget what they're called because they're really long names. They insert an electrode and then not a pacemaker, what are those things called? Oh my God, it's on the tip of my tongue. Like a regulator type thing that communicates with that electrode, and that helps a lot for people who are treatment resistant. Basically, it's all right. It does what the medication should have done. So clients will still need therapy, but again, it provides that scaffolding and takes the edge off for the client to do the rest of the work. So for whatever reason, the medication's not enough, and they need more support to get the same response. Right. Okay. Any questions about DBS?
So I guess, would you get many at that level, Celine, that would choose DBS?
Not too many. In Melbourne, there's a couple of the hospitals that offer it, St. Vincent's and Royal Melbourne. The criteria at Royal Melbourne is quite stringent, so clients have to have exhausted nearly every single medication combination. They have to have done ERP for like a really long time. They have to have been through the inpatient program at the Melbourne Clinic a few times, because it's brain surgery, it's fairly invasive, and so there's a review board. So I think in the last, I guess 6 or so years that they've been offering it, only I think maybe 10 to 15 patients have gone through. So not too many. I mean, it does seem like a lot, but when I was still working at Melbourne Clinic, they only had about 3 that had gone through at that time. And it's nationwide, so yeah, not too many. About 20% of people remain treatment resistant. And then, yeah, so I guess if they're in that category, then they might be on the trajectory to eventually needing DBS. Does that answer your question?
Yeah.
Right. Hi, Leanne. How are you? Okay. Oops. All right. So I'll now move to talking about the psych therapies. So we've got there are different variations. There's CBT with exposure response prevention, ERP alone, and then now we're looking at mindfulness-based exposure response prevention. So CBT with ERP came about as a result of the research done with Koskis and his team, and they're from the UK. Has anyone seen The House of OCD on TV? Many years ago now. So his group have done that, and basically their idea is OCD because of the faulty appraisals that people make when they experience an intrusive thought. So they're very much in that camp of the intrusive thought pops in, people respond to it in a negative way, and then because of the thought, OCD develops. But what we're recognizing now is more of this inhibitory learning model process where the thought pops in. Yeah, sure, people interpret it in a particular way, they react to it, but the stress that then causes is what leads to the compulsive behavior. And if we think about it, it really then becomes this idea of it's not so much the content of thoughts, it's the process, it's that reaction, that inability to regulate the distress that makes it hard, because thoughts are there, but it's then how it's making the person feel that's then making the person think, okay, well, this feels really uncomfortable, this feels real, I need to get rid of these feelings. What can I do to make myself feel better? And so the cognitive theorists thought that the mechanism for change for treatment was about achieving habituation, in terms of extinguishing behavior, so very much a behavior therapy perspective as well, by then saying, okay, well, the more we expose people to this, then they'll get used to that and reach a level of habituation that'll then distinguish, etc. But what research has been showing us is that that's not necessarily the case, because people would still experience fear, uncertainty. So the idea was, through this inhibitory learning model, that what we need to do is engage in exposure, but build a new evidence base. So we're really building new neural pathways for people for that then to become the stronger pathway, I guess, over time, through repetition, through consistency. And so the more people engage in the neutral pathways or the non-compulsive pathways, if that makes sense, the more they resist in engaging in compulsion, they're then building some of those new pathways so the brain has a viable alternative. Does that make sense? Because if we pathways that are neural pathways that are created in fear don't really extinguish, because the primal response, we need to hang on to those, we need to remember those in order to keep us safe. So it comes down to that fight-flight response and the mechanism of what's involved in that. Any questions? All good? Have I lost anyone in terms of those two models? No? We good? Okay. All right, so here's looking at exposure response prevention with CBT. They're fairly comparable except for group. And so we'll see that that group CBT is less effective than either individual CBT with ERP or ERP only delivered in a group. So clients will often tell you that too, in terms of the cognitive work, by thinking about rational alternatives or challenging intrusive thoughts in a particular way. Clients will often talk about feeling patronized, or feeling like they'll always say things like, yeah, but blah blah blah, or I know it sounds silly, but X, Y, and Z, or I know this doesn't make sense, and A, B, and Z. So really what we're starting to recognize is clients can rationalize and know, right? So there's that insight there. But when they're in the moment, when they're in that heightened emotional state, they lose access to that, in terms of, if we think about that fight-flight response, and our frontal lobe shutting down, if that part of the brain that's responsible for regulating anxiety is overactive in terms of the amygdala, then how can we access that cognitive information? So I think it serves a purpose, it's helpful, but to a certain degree. So we really want to help clients get mastery over that. Yeah. Has anyone noticed that with any of their clients?
Yeah, I think definitely. Many of the clients can articulate and verbalize that they know it doesn't make sense, and it's, they know it's not logical, but at the time, they just can't often engage those CBT strategies.
Yeah, it makes it frustrating.
I found with another client as well that going through that cognitive challenging, whatever the thought was, the description,
Yep.
once we got to the end of that and he was able to say, yeah, that's unlikely to try, don't believe that, you know, a lot. He said, but I don't think I used the right word. And the word would change, and then we'd do it again, and the word would change, and we'd do it again. And we get to the point where he goes, I don't think I can articulate what it is.
Yeah.
So it was really sticky, but we couldn't really hold on to it to chip away effectively.
Yeah. And OCD is really sticky in that way. I always talk about OCD in the third person because it's like this other process that's happening to the client because of that dual process in terms of them being able to engage with you in a conversation, but the background process happening. And so OCD can be really sneaky in that way where it will manipulate things and manipulate the situation to kind of hang on and stay in play. And I find that the more we engage in the content of the thought, you get involved in this really circular argument with OCD, i.e. the client. And like you said, it becomes really hard to kind of chip away at that. Yeah. Okay. So this slide really talks about what I've been talking about. So I won't go over it again in terms of you know, treatment in terms of exposure response prevention on its own isn't always well tolerated because clients, you know, are asked to face their fears and it can be really scary. If I said to you guys, I want you to take out a piece of paper and I want you to write down, I want insert name of the person you care about the most to die tonight, how likely are you to write that sentence down? Pretty unlikely, I'm assuming, unless we're all really evil and sadistic on the inside. But essentially, that's what we're asking our clients to do. We're asking our clients to be okay with tolerating that level of risk of putting something out there and being comfortable with sitting with that. And so, you know, we're taking away their compulsions in a graded way through exposure response prevention. But then we're asking them to feel anxiety, which is what we want to do. We want to build tolerance to that. But at the same time, we want to give them helpful coping strategies. And pure ERP OCD therapists would probably shoot me down for that. But I think if you're working in a hospital setting, it's wonderful to do pure ERP because you've got staff and support around that person to help provide that scaffolding. But when you're working in a clinical setting and you're spending an hour with them and then sending them home, they need that support to help them get through it during the week. And these, what we find is these mindfulness-based tools are really ERP friendly, and we'll go through that. And in a sense, can be like ERP when they're practicing some of those tools. So, in terms of research, some research that's been published that looks at mindfulness-based approaches with ERP, and there's a guy called T-W-O-H-I-G is his surname. He's doing a lot of mindfulness-based work, which is really cool, and has some recent articles too that are out there that might be worth reading if you want to read it a little bit.
Sorry, Celine, who is that person? Can you spell that again?
Yep, T-W-O.
T-W-O, yep.
H-I-G.
Okay, thank you.
Okay. So just kind of keeping that inhibitory learning model in mind, what we really want to be doing is helping clients build their skill base and form new neural pathways so that they can separate from the content of OCD and really bring their attention to the process. going on, relating their distress, and not allowing OCD, I guess, to dictate what they're doing. So they're focusing on their function rather than, and process rather than content. Okay, the other advantage of the inhibitory learning model is that it promotes the client to be adaptive and to be flexible in their thinking, because we're creating a viable alternative. So it's like saying, okay, well, instead of driving home this way all day, every day, what are some other ways of driving? What are some other ways of
Sorry, Celine, I'm sorry, can I interrupt there? There's someone's mic is really loud, and every time there's moving a paper, I can't hear you. There's a lot of...
Oh, okay. All right.
Yeah, it drowns out your voice, Celine.
Okay.
I think, Alina, I think that might be you because you're...
Let me try move it away. Hold on. Is that better if I move the paper?
I think so.
Yeah, that's better.
Okay.
Cool.
I'll leave it there.
Sorry. No, you're good. All right. So what we want to do with the inhibitory learning model too is allow clients to be able to have a choice so that they can shift gears. So when they are building that insight and noticing that, you know, OCD is trying to dictate things, or OCD is trying to tell them what to do, or, you know, it's creating urges to pull them in down that rabbit hole. We want them to be able to recognize that with these exercises, to then go, okay, this process is going on, but I have a choice here. I can choose this pathway versus the pathway that I'm trying to do. And of course, that needs to come with consistency and repetition and all the rest of it, because if we're creating change, you know, as we know, the brain is like a muscle. We need to exercise that. We can't just have it as it is and do things once or twice, because then change isn't going to happen. And so a lot of the time when we speak to our clients in this transparent way and explain to them what's going on and the process behind it and those mechanisms of change and what's happening in the brain and all the rest of it, you usually find that they're on board with you every step of the way, and it makes it easier. Any questions or comments about that?
Could you give an example, Celine, maybe if you think of a client that you've worked with before with particular obsessions and compulsions, and give an example of how you would, say, talk through this model and the work you're going to do?
Absolutely. That's one of the, when we come to the session structure,
Yep.
I'm going to talk you through step by step exactly what I do, how I do it, and and what that session looks like.
Okay, thank you.
Sure. Yeah, definitely. I've got 2 case examples too that I'll be talking about throughout the entire program and applying this stuff to the cases too.
Great, thank you.
Okay, so that we've talked about. That's more on DBS. Done that. Okay, any questions about any of that stuff that we've talked about so far? So that, I guess, is rationale for mindfulness-based exposure response prevention, where the research is heading and all that sort of stuff. And now we're going to really get stuck into the nitty-gritty of it in terms of what the rest of the program is going to look like. So I'm going to spend time talking about a rough session structure. Obviously, it's not linear. It might take you 3 sessions to do assessment and diagnosis, but I've got it as session 1. You might do psycho-ed over 2 sessions. So obviously it's flexible, but I've just done it this way as just an easy way of, I guess, sharing that and communicating that. So session 1 is where I, you know, meet clients, do a semi-structured clinical interview, all the rest of it. And basically set therapy up. It's not rocket science. It's something that we all do. And then at the end of that session, I'll say to clients, you know, next time I see you, we're going to be talking a little bit more about the treatment model. I'm going to share with you what that looks like how the tools and strategies will help, how exposure works, what happens in the brain, and so on and so forth. And usually you get buy-in at that point in terms of, I guess, selling mindfulness-based ERP. And clients can then ask questions, etc. And we go from there. So I guess it kind of really sets that therapeutic process up. In the third session, that's when I start working with clients to create a hierarchy in terms of exploring their triggers and sorts of things in more detail. And then in session 4 and 5, we start building their toolbox, where we talk a lot more about introducing the mindfulness-based skills. And then after they're confident with that and comfortable with those skills, we apply it to ERP. So session 6 and 7 is really more about exposure response prevention. And then that can take however many sessions you need. And then from there, we look at things like relapse prevention and maintenance and all that sort of stuff. Any questions?
Celine,
yeah.
If you've got a client who has a wide array of, so we're working on triggers here, there's a wide range of compulsions.
Yeah.
I guess, when I think about it, I probably have been more compulsion focused.
Yep.
There's a whole laundry list of areas and targets.
Yep.
Are you saying that actually it's better to target the obsessive thoughts and get them as the list?
I usually do a mixture in terms of I'll often say to clients, what are the intrusive thoughts, or like what are the categories of intrusive thoughts that are an issue, and then what are the associated behaviours. And so I usually will construct exposure tasks around that category based on where that kind of sits in their hierarchy. And then we look at, okay, how can we slowly take away some of these associated compulsions?
I guess my experience, again, with the limited amount of clients that I've worked with is that, and it probably will be the way that I'm setting up the hierarchy itself, but it's actually quite exhaustive.
Yeah.
And you look at this ladder, and the client's kind of like, well, at least they already know all these things are happening, but they go, well, at least we get to do it one step at a time. But my thinking also is, I'm looking at this going, oh my God, my treatment is going to be a long time.
Yeah, it is. It is. Yeah. You're usually up for about 18 months.
All right.
Yeah.
Well, that kind of normalizes it, I guess, then.
Yeah, it does. Yeah. A good 12 to 18 months and they're not going to come in every week for that whole time. But for the first 3 to 6 months, they'll come in every week to fortnight. And then after that, you can stretch it out. The more comfortable they're feeling, the more confident they are, and the more gains that they're making. Because by then, within that 3-6 month mark, you would have made a really big dent in their hierarchy. So once you kind of get the ball rolling, it kind of starts to snowball from there. And when they get really positive experiences, they then start to be their own therapist, really, and will start to challenge themselves with other things. And then from there, you might meet once every 3 weeks and then eventually once a month through that maintenance and relapse prevention phase.
Okay.
Yeah, but it's long-term work. So if you think about how long they've been doing it for versus how long you need for those neural pathways to be established, it takes time.
That's a nice way to think about it.
Yeah. And that's how I share it with clients too, because it allows them to then go, okay. And I'll say to them, like, you know where you want to be, but you've got to give your brain time to get there. Right? Yeah. Yeah. But it can be, we'll get to hierarchies, but it can be a bit of a mix sometimes, where sometimes it'll be the obsession and sometimes you'll be focusing on the behavior. Especially when there's mostly mental compulsions, because the person has more of a generalized anxiety, like a primary diagnosis of generalized anxiety disorder. And so and then it becomes obsessional, and then they're ruminating and all the rest of it. And it becomes really tricky to even have a hierarchy sometimes. Yeah. Any other questions or comments? Okay. So session 1, there's a lot, and I might, how are people going in terms of what they've allocated for this session? Are you all good to keep going for a little bit longer?
Yep.
Yep.
Yeah? Okay. So, as I've talked about before, we want to make sure that the thoughts are ego dystonic. We've covered that, so I won't go over that again. Okay, this one's important to note in terms of compulsions aren't often connected in a logical way or a realistic way. And clients will very easily be able to rationalize or justify why they're doing that particular compulsion. Like they might say, I have to wash my hands 3 times, or I have to neutralize this thought 4 times because something bad might happen to my mum, or something else that might come up. Or if I don't say this prayer 5 times while cooking dinner, then I might stab my partner, or I might, molest my child or something like that, which is really distressing. And you might ask, what's special about 4 or why 5? And they might give you a reason, or sometimes I'll say because it feels right. So sometimes there's a not quite right feeling attached to it, and clients will do things until it feels right. But they might not necessarily be able to articulate what right feels like. It's just the feeling. Yeah. Compulsions are quite distressing. And this is where it's different to someone who might be presenting with an ASD or an autism spectrum disorder. And Tracy, this one will be important for you. And you might have noticed, you can correct me if I'm wrong, in that repetitive behaviours associated with something like an ASD are actually soothing and pleasurable, versus a compulsion, which is also a repetitive behaviour, but they're distressing and the person doesn't want to do them. Have you noticed that difference, Tracy?
Yeah, definitely. A lot of the ASD repetitive behaviours are sensory related, and sometimes cognitive distress, but often sensory or physiological distress. It's very relieving for them.
Yeah, cool. Okay. We've talked about it needing to be time consuming. So here are some specifications. With good or fair insight, which is most cases, most people with OCD will have good insight. Like, I know it doesn't make sense and all the rest of it. Very little percentage of people will have poor insight. And so you might specify that there are some delusional beliefs associated with it. And I find that people can slip into poor insight when their anxiety is through the roof. Like, it's really intense. They're so activated that anxiety has just taken over, and they've lost that ability to rationalize. And that's because, well and truly, their frontal lobes have shut down. But once things have settled, and once the anxiety has settled, insight comes back, if that makes sense.
Yeah.
Okay, so we've just talked about that. Tic disorder is also a specifier, and that's something that you might ask during that assessment process and find that out. Okay, so we don't have any Australian data as yet, but I know that there's a small group of advocates in Victoria that are trying to get that going, which is pretty awesome. And I think they recently just got some government funding to do that, which is pretty good. But the data in the United States is that the prevalence of OCD in the US is 1.2%, and females are affected at a slightly higher rate than males. and usually it starts in adolescence, although for a lot of people it can start earlier as well. Okay, so the mean age of onset is 19.5 years. 25% of cases start by age 14, and we think that because of puberty, it can kind of coincide with that.
Yeah, I'd love to see some research done in that area. The majority of the males that I see with, a few little quirks, if you like, or little or with anxiety, when they hit puberty, that OCD goes through the roof.
Yeah, absolutely. Yeah, it's really interesting to see the difference. And then usually by the time they get to like 18, 19, it settles down again, like it's still there, but at a much more manageable level.
Yeah.
Yeah, it's quite interesting. Okay. Without treatment, remission rates are quite low. Onset in childhood or adolescence can lead to a lifetime of OCD. So the earlier it starts, the more chronic it is. And up to 40% of individuals with onset in childhood can have remission by early adulthood with obviously appropriate treatment. And it can be complicated with the occurrence of other disorders, like things like depression or ASD, or generalized anxiety is another one, which is really common. Okay. In kids, it's more, you can observe it, the compulsions are much more observable, and as they mature, that then internalizes and becomes mental compulsions. And as you're assessing someone, they're describing the trajectory of their OCD, they'll often say, when I was younger, I used to avoid stepping on cracks, or I used to avoid this, or I used to avoid that, and so on and so forth. But in present day, when they're a young adult or an adult, they're talking about it in a way where they've got mental compulsions. Okay, temperament. So these are risk factors. Temperament is a risk factor in terms of people who are described as being high empathy or high empath, or who internalize a little bit more, or who are described as being sensitive. That all makes a difference. Environment is another one in terms of if they've been exposed to trauma, whether it's neglect or physical trauma or something else that they might be experiencing. There's also some research about infections and different infections through autoimmune issues causing or contributing to the development of OCD too. I'm not quite sold on that research, but it's there. And
is that similar to that PANDAS?
Yes, definitely. Absolutely. Has everyone heard of PANDAS?
No.
No. It's a really long acronym, and I keep forgetting what it stands for, but it's...
Can I say?
Pardon?
It's pediatric autoneuron disease after streptococcal.
Thank you.
Wow.
Yeah. So basically it's and correct me if I'm wrong, Tracy, it's repetitive occurrences of infections during childhood that have been said to contribute to the development of OCD.
Yeah.
Yeah.
You're right. There's a lot of people, a lot of pediatricians as well, that do not believe in it. But we had one very, very, very clear case. So, and it doesn't have to be a, what would you say, a severe case of strep. So that, that's our tonsillitis.
Yep.
But the strep can break the blood-brain barrier. But we had one young lady who hers was quite severe, and it was quite marked. No history of OCD behaviours or anxiety. Yep. And then within a week, florid OCD. It was very debilitating. They actually gave her a blood transfusion. So it's quite horrible intervention, but she's fine afterwards. So.
Yeah, that's good. And that's often, it is quite quick, like you described it being within a week. That's often the case, you know, within a very short period of time, you get this full-blown episode of it. Yeah.
And are you saying, Celine, in these cases of PANDAS or whatever, or just generally that it can creep up that quick?
It's mostly for those cases of PANDAS, for people who feel like it's just a switch is being flicked, it doesn't really get so severe so quickly, but it's more a slow burn process. But in terms of that development. But some people will still say, you know, I kept getting these really intrusive thoughts because I saw this thing on TV and I just couldn't get it out of my head. And they get stuck on the content. But usually if you probe enough, it's because it was there, but they weren't really paying much attention to it because it was distressing. But that was enough to push it over the edge. All right. So in terms of genetic and physiological risk factors, there is a genetic element in terms of if there's a family history, then it's likely that that'll get passed on. And the part of the black brain that's implicated, and this is where DBS plays a part, are these parts of the brain here. So the orbitofrontal cortex, the anterior cingulate cortex, and the striatum. That's what research shows. Okay. In terms of cultural indicators, there's substantial similarity across cultures in terms of cleaning, symmetry, hoarding, taboo thoughts, fear of harm, etc. But there's, you know, differentiation in terms of what means more to one culture will be different amongst another, and so on and so forth. Research shows that males have an earlier age of onset and are more likely to have comorbid tic disorders. You'll sometimes see gender differences in the pattern of symptoms and the topic of symptoms. And in terms of suicide and risk, a lot of clients will have fleeting thoughts. Not too many would have acted on it. But you know, you still get, especially if you've got comorbid depression, you'll still get a lot of clients who will have that sense of hopelessness and helplessness, and also this underlying, which kind of creates this underlying idea of, you know, what's the point? Treatment's not going to help, etc. And just have this really defeated attitude because they've been dealing with it for so long and just don't kind of see any way out of that. So that. All right, differentials. We've got generalized anxiety disorder is probably the most common one to kind of distinguish it with, which is so tricky. A lot of clients with OCD will have that undertone in terms of then dealing with other things like specific phobias and social anxiety disorder as well. So I've got there some information about how to kind of disentangle it, and sometimes you might diagnose both. For that reassurance seeking or whatever the compulsion is in regards to the trigger. Any questions about differentials for this?
Celine, do you get many? Oh, you got it in there. I'm going to ask about the phobias side of things.
Yeah. So phobias, yes, but what will happen is the avoidance, the reassurance seeking, the compulsions that the compulsions that happen with that can be quite specific, but at the same time usually they'll have other things too, so we work it in the same way. Yeah, it's I find with the anxiety disorders we can't really separate it too much, because it's not as clear cut, because when people experience anxiety disorders, they have difficulty tolerating uncertainty anyway, or they want a bit of reassurance, or they'll engage in behaviours to make them feel better. I notice though that it's not as intense as someone with OCD. So the intensity isn't as strong. The other thing is too, with things like phobias and some of the other anxiety disorders, there might be reactions to what's going on, but it's not necessarily repetitive. And that's what I mean by intensity, in terms of how they deal with it and how they respond to it. Does that make sense?
Yeah.
Any other questions about that? So we've got major depressive disorder. So it can be distinguished from the rumination of major depressive disorder, where thoughts are usually congruent with mood, and not experienced as intrusive or distressing. And ruminations are not always linked to compulsions. Rumination will be about mood as opposed to about the trigger or the obsession. So that's the difference there. Disorders, there's always, I think we're getting static from someone's mic. I can't figure out who it is. Can you guys hear me still?
There is more noise going on, unfortunately.
Yeah.
That's all right.
I try to move mine away. I don't know.
I can't tell who it's coming from.
I think Alina's screen lights up. So sorry, Alina, but it is coming, I think, there.
Is it? What can I do? Can I turn my mic off? Or
If you want, you can, there should be a mute button down the bottom to the left where you can hear me, but then we can't hear you.
Yeah, let's try that.
Okay, but if you have a question, just unmute and shout out. Okay. Eating disorders is a really commonly misdiagnosed disorder. We usually get, especially people with contamination type OCD, we used to get them coming into the hospital where they're incredibly thin, but people are restricting food not because they don't want to eat or they're worried about body image or shape or anything like that, but because they want to avoid the 3-hour ritual associated with going to the toilet or washing hands or prepping food or whatnot. So clients will, for example, if they've got a 2-hour toileting ritual, they'll avoid eating, because if they eat, that means that their body's going to process that and they'll eventually have to go to the toilet. So to avoid going to the toilet, they'll avoid eating. And your client will say, I want to eat, but at the same time, I'm terrified of that. I'm working with a client at the moment who only eats certain types of food because the rest of it feels not quite right. And the uncertainty of what that might feel like in her body feels strange. And so she then restricts, but she wants to eat, but feels stuck in that. And she used to be able to eat just about everything, but then got diagnosed with a nut allergy. So then she started looking at packets, and then every time she saw that it had traces of nuts, she would then restrict that. So it was I guess grounded in quite a logical thing, but then that became unhelpful, where she just then started avoiding everything. And it's been so long since she's been eating a bigger repertoire of different foods that She feels like she's forgotten what it tastes like, etc. And now it just feels weird and wrong and whatnot. So we've been working on some of that. Yeah. Any questions about eating disorders? I think I go into it a little bit in more detail.
Yeah, I've got a fellow very similar to that, Celine.
Mm-hmm.
Yeah, and his primary diagnosis is a phobia of vomiting.
Yep.
But he's probably one of the main reasons why I'm engaged with this training, because I feel like I'm missing maybe some OCD with him.
Yeah.
He's really treatment resistant, and he's so thin.
Yeah, yeah. And that's emetophobia, that's quite common, where you end up with that OCD type presentation of you've got the phobia happening, but then the way that he's dealing with that is more in that OCD way of his obsessions are around food and cleanliness, I'm assuming, and contamination, and might avoid things like chicken especially. He might check use by dates on food, etc. And so that response becomes the compulsive part.
Yeah.
Yeah.
Yeah, he's avoiding even water at school now.
Yeah.
Really worrying.
Yeah, absolutely. And it's quite distressing. He's probably starving and saying things like, you know, I really want to eat, but I feel like I can't. Yeah.
Yeah.
Okay. Yeah. All right. I've got OCRD there. That just means obsessive compulsive and related disorders. That's what it's called in the DSM. And I've somehow, while doing these slides, switched into writing that acronym instead of just sticking to OCD, but really just mean the same sort of thing. All right, so just kind of going on to those differentials, people with eating disorders will usually restrict, binge, purge, etc. because of fear of gaining weight, their body weight and shape, etc. But people with OCD won't have any of those thoughts. Theirs will very much be tied into the trigger, whatever that might be. They'll worry about, bless you, worry about getting sick or vomiting, or wanting to avoid the ritual that's associated with it, or it doesn't feel right, or so on and so forth. Oops. Okay. Body dysmorphic disorder, the obsessions and compulsions are limited to physical appearance. And then trichotillomania, it's hair, but they're common. They co-occur a lot of the time. And hoarding is the other one, where the difficulty is and the thoughts are to do with possessions and having trouble getting rid of those. The one I want to focus on here is, I won't go through tics because it's not too common, but it's there in terms of the tic is different to a compulsion in the sense where it's a stereotyped movement and it's less complex as opposed to a compulsion. A compulsion can be a quick reaction. It can be really, really quite complex and ritualized and repetitive, whereas tics aren't usually as repetitive as a compulsion is. Psychosis is the other one. So in psychosis, we want to test for reality and doubt. As I mentioned before, if it's ego dystonic, then you're likely dealing with OCD. If it's ego syntonic, you're likely dealing with perhaps psychosis in terms of beliefs and so on and so forth. Usually the beliefs are quite bizarre in nature, as we would see typically in someone with psychosis. Okay, so I've got a bit of a case study here. I'll give you a moment. It goes over 2 slides. I'll just move this. Maybe up here. Yeah, is that better? Yes. So I'll give you a moment to read through that. Basically what this does is it shows it is a case of someone who has OCD, but when you read it, it seems like they could possibly meet criteria for psychosis. Are we right to switch?
Hold on a sec.
Oh.
I've only done number 1.
Oh.
I'm all good.
You good, Tracy?
Yep, thank you.
Yeah. Jenny and Alina, you good?
Yep.
Okay. All right, so here's the second part. What do we think?
Poor darling.
Yeah, it's pretty full on.
It definitely seems from what he talks about that he believes in the thoughts that are coming up and the content of the thoughts.
Mm-hmm.
There doesn't seem to be a marked difference about that at all, besides the fact that he wants to be on the good side, but
Yep.
Which lends me to think that it's more psychotic.
Mm-hmm. Yeah. What part of that would make you feel like perhaps there might be some OCD in there?
I guess the compulsions that continue to occur throughout it, and that he does get, it was even on this slide, he does actually get relief from those compulsions.
Yeah. Absolutely. And so you might maybe think about delusions as a specifier because the belief is there. Any other questions or comments about that?
Sorry, Celine, so I'm just wondering, so the primary diagnosis then would not be psychosis, it would be OCD with that delusional specifier, is that right?
Yep.
Okay.
Mm-hmm. And it gets tricky.
Yeah.
It would depend a lot on what else is going on.
Absolutely.
Aside from that set of symptoms as well. Absolutely. So, you know, is there a more complex delusional system that's going on? And is he disorganized? And
absolutely.
I mean, there was some mention of possibly, you know, an auditory hallucination. Does he experience them and how do we differentiate them, I suppose, from the obsessions. But I guess you'd want like a bigger picture of him as a person.
Absolutely, absolutely. And looking more at the negative symptoms of psychosis too, and seeing if there are any presence of those, and that level of functioning.
In this example, is the thing that is swaying it to OCD with the delusional specifier, if we just take it on what it is, simply the compulsive behaviours themselves, or is there something else?
In this example, it's really more of that. So with the obsessions, there's the belief there, so that becomes that delusional specifier. But absolutely, it's more the behaviour and the response. If we do take it as just this, that's what sways it into that category. Yeah.
Interesting.
Yeah.
Is it not just OCD because he can see things as well? So he can see like the black dot. Does that make it the more psychosis?
Yeah. It's down that trajectory. And a lot of psychiatrists will, when they're talking about OCD, will say that for them it's like a spectrum of that type of neurosis, I guess, where you might have OCD which protects people in a sense. It's quite a dynamic way of thinking about it. OCD protecting people from venturing into the path of being psychotic, if that makes sense.
This just reminds me about a client from, probably closing on a decade ago now, seeing in tertiary services, who had OCD relating to toileting and defecating, and he had hours and hours of rituals relating to that. When he didn't have a huge amount of environmental stresses, but when the environmental stresses came up, that completely went. He was able to go to the toilet, but he became paranoid and very delusional that his extended family were trying to kill him.
Yeah.
And it was very psychotic, and it had some auditory hallucinations.
Yep.
And it really seemed very switch-like it was one very black or white.
Yeah, absolutely.
Based on external stresses or the absence of.
Yeah, and that can happen. I've got a client like that at the moment who has a diagnosis of OCD, but when his stresses become really intense, it pushes it to that level of psychosis and becomes very paranoid, can get quite angry and aggressive towards those around him if they're trying to rationalize, but there's a real intense need for reassurance. But interestingly, he doesn't respond to antipsychotics, and some people don't, as a main form of treatment, even though some people are prescribed a mild dose to augment their SSRI. Some people don't respond to it. But once the stressor is no longer there, it's like that anxiety comes down and the paranoia and all the rest of it starts to alleviate. It's an interesting process. Yeah. Cool. All right. We'll just move this back over this way. All right, so we've got, if OCD is present, maybe not, let's back up here. All right, there's a clear link between the intrusive thoughts and rituals, if they're repetitive. So we're focusing on the behaviour, and they're compelled to carry it out to relieve anxiety. The other thing too is, generally speaking, you can still hold a relatively normal conversation. And if you probe enough, then the client will often tell you, I know that this doesn't make sense, but a lot of the time they're preoccupied with doubt and uncertainty, which lends into that paranoia. And sometimes it does go over and cross over into a psychosis type presentation. So it's really complex and quite tricky when we're dealing with clients. But often when clients get to that stage, as Nathan mentioned, they present to the tertiary services. So you'll find them in ED and that sort of stuff. Okay. A lot of the time, if someone's been misdiagnosed with psychosis, they won't respond to antipsychotics, but some people do. So it's trial and error, unfortunately, a lot of the time when we're dealing with that prickly end. All right. So one thing to note here, what this slide talks about is things like other addictive behaviours, which can look like compulsions, really to alleviate a lot of the distress that's happening. And a lot of people will say, you know, when they're dealing with OCD, they'll say things like, I feel like I'm addicted to it, or I feel like I'm dealing with a drug addiction. And it's not a dissimilar mechanism in terms of, you know, every time someone engages in a compulsion, the reward pathways are also activated, and so on and so forth. Okay, obsessive compulsive personality disorder. I think this is the last different, oh no, we've got ASD as well. Obsessive compulsive personality disorder. In this, the person, generally speaking, the person really doesn't see anything wrong with their intrusive, with their obsessions. Basically, people with OCPD are quite, I guess, undisturbed by their way of doing things, and don't think that there's anything wrong, and usually it's the family that complain and feel like the person needs treatment, but it's consistent with their values and beliefs, and usually speaking they will try and impose that way of doing things on other people. Everyone else needs to change, everyone else is doing it wrong, and so on and so forth. So that's usually the kind of comments that you'll get from people who might fit the OCPD category a little bit more. Okay. So going on to ASD, the big difference with this is what I talked about before in terms of when repetitive behaviours are present, and they're soothing, it's tied in with that ability to what's the word I'm looking for? To help them regulate, but in a helpful way, versus and they actually want to do it and they find it soothing, versus being distressed by it. And they co-occur quite a lot too for a lot of kids with ASD. Okay. So individuals with OCD can often have another form of psychopathology, as we've been talking about. Depression is the most common one, as well as at least one other anxiety disorder. And it says there too that up to 30% will have something like a tic disorder as well. So quite a few.
Yeah.
And did someone have a question?
I was just saying, all of my Tourette's disorders have OCD as comorbidity. Haven't got anything out.
Yep. Yeah. So there's quite a big overlap. Yeah. Okay, I think we've gone through some of these stats from before, so I won't go through the same set. This one's an interesting one, where it talks about 14% of people with OCD won't be able to hold down a job. And that's a lot of people if you think about only a certain percentage of people experience OCD, but it's still a lot. But 14% of that population won't be able to hold down a job, which is a lot of people. And so hopefully we'll be able to get the Medicare funding that we were supposed to get in terms of 20 sessions being funded a calendar year for people with OCD. So what happened with the eating disorders is what they're hoping to do. But at that time, I think the debate intensified with the whole profession anyway, in terms of the tier system and whatnot and all the rest of it. So I think that's kind of put a bit of a hold on things until we can work out where to go with it. So hopefully that will go through, and that means that people will be able to access treatment more consistently. It'll make it more affordable, and return people back to the workforce as well, which will be good.
Just, you know, a bit of an outside of the box question, Celine. Just leading up to this today, doing a bit of reading and stuff, it did make me think, in my private practice, I work bulk billing. So there's a big proportion of my clients that struggle to go past 10 full stop. And one of the things that I was thinking, because I'm hoping to kind of fill some of the gaps in this community around treatment of OCD, was, you know, having a bit of an intake list or a waiting list towards the end of the year, starting towards the end of the year with 10 sessions, and then you can continue that care for another 10 sessions into the next year. Have you heard of anyone trying that model before, or would there be any inherent barriers or things that you can think of that wouldn't work to that?
No, not really. You do find that I know in our clinic, we're busy, but our referrals just hit another level of crazy come October and September. And I think it's because people realise too that if I start now, I'm going to get a solid 6 months of therapy. So absolutely, I think that's a great idea in terms of, you know, doing an intake and building clients to there so that they know that they're going to get a solid 6 months. Yeah.
Sure.
Yeah. All right. So with all that through the assessment process, there's a lot to consider, obviously. The types of obsessions and intrusive thoughts that you might see, some of the examples are here. So, and this isn't the end of it. There's so many. But these are the main, I guess, categories or topics. So you get contamination is one of them. Dirt, germs, environmental contaminants, you know, poisons, whatnot, the rest of it. The list is endless. Aggression, violence, and harm to self and others is another one. So people will get thoughts of, for example, stabbing someone or punching them or molesting or running over someone with their car and driving off or something like that. Order and symmetry is another one, which is where people like their environment to be ordered, etc. Scrupulosity, so that of the moral kind or the religious kind. So basically that's where people have a strong moral compass and have this sense of things being right or just. And people will often think in a fairly black and white way, things are either right or wrong. So that comes under that umbrella. Health anxiety and triggers to do with the body is another one. Saving and loss is associated with hoarding. So worries about needing to keep things versus have I lost something? So they might check their phone, wallet, keys, etc. Superstitious obsessions are another one. Things like, you know, touching wood or not walking under ladders or avoiding black cats and whatever else it might be. People might experience doubt of daily activities, a pathological doubt. Did I send that email? Did I do this? Did I do that? So constantly going back. Did I fill that paperwork out correctly? Sexual content is another one, children, incest, homosexuality, or the relationships. So am I in the right relationship? Is this person the right person for me? So on and so forth. Existential, what are we doing here? What is the meaning of life? And so on and so forth. That's often associated with death anxiety. And just generally other intolerable thoughts. Has anyone seen anything that I haven't listed?
There was one case that came up. I follow a couple of consumer Instagram things, and there's an OCD one. And it just ended up coming up that the waitress at the cafe that I go to popped up.
Yep.
And she had the obsession of being nuclear.
Oh, yes.
Radioactive.
Yep.
And that she would be responsible for poisoning other people.
Yeah. Yeah. So that comes under that harm to other people. Yeah, absolutely. That's an interesting one. I kid you not, people with OCD have the most amazing imaginations and they're so creative. But the downside to that is their mind will take them to weird and wonderful places. Yeah.
Yeah. The other ones I can think of, but I think it comes in under contamination.
Yep.
Selena's like had a couple of teenage boys that wouldn't sit on chairs that maybe their mother had sat on or their sister.
Yep. Yeah. Because they're considered dirty or whatever else it might be. Maybe not dirty, but they might not want to take on their character or their personality characteristics.
Yeah.
Yeah. They don't want to be contaminated by that person.
Yeah.
Yeah, definitely. Okay. So types of compulsions are excessive checking, reassurance seeking, clarification, over-confessing, hand-washing, cleaning of self and or objects, ordering, rearranging, repeating actions, touching, tapping, blinking, staring, covert mental rituals, including thought blocking, singing songs, using humour, self-coping statements, etc. Excessively saying sorry, thank you, unnecessarily explaining their behaviour to avoid offending others, so on and so forth. Hoarding of objects, avoidance in general, rereading, rewriting, and it can go on forever. There are so many different compulsions that people can do. Basically, you want to look for what does the client do repetitively to make themselves feel better when they're triggered in this situation. Okay. So the next few slides has got examples of questions to ask of your client to elicit different obsessions and different compulsions. I won't go through all of them, but there's some practical examples there of ways you can word your questions to elicit some of these responses and gain that information. Okay.
So I'm just screenshotting that. So
yeah, that's good. That's okay. Can you see it?
Oh, yeah, all good.
All right, so psychometrics for assessing. I mostly use the Yale Brown Obsessive Compulsive Scale, and I sent you guys 2 versions. There's a full-length 21-page version. I rarely use that one. I usually use the other one, which was just a couple of pages, like I think it's 4 pages altogether. So the first component of the Y box is a checklist, where the first page asks about obsessions, the second page asks about compulsions, and the client just ticks the relevant one. If it's currently a trigger or has been a trigger in the past, they tick both. If it's currently a trigger but never been a trigger, they tick the current column. If it was a trigger in the past but not currently, they just tick the past column. If it's relevant, they tick it. If it's not, they leave it blank. Then the second component of that is the severity rating scale, and it's sensitive enough to use every week. So if you want to track your client's progress on a weekly basis, you can. I don't usually do it every week, but I'll do it at least once every 3 or 4 weeks. And that gives us a really nice way of going, okay, is this score coming down? So lower scores indicate lower symptomatology or severity. higher scores indicate higher severity or more chronicity or whatever you want to call it. So again, the first of the severity rating, the first page of questions relates to obsessions, and it'll say things like how much time do you spend on obsessions, how distressing are they, can you control them, can you resist them, so on and so forth. And the second page is about compulsions, including mental compulsions. Any questions about that? Okay. So what I might do is we've come to the end, and we might finish off with this video. So next week, so that's all session 1 for today, and I know it was pretty heavy going with a long session, but I'm going to finish off with this example, and then next week what we can do is we can open up with the case study examples that we're going to use for the rest of the program, and the rest of it will be more applicable. So next week's session is going to be the psycho-ed component. So Kate, that's what you were referring to earlier. So it'll be about how I explain it to clients, how I get that buy-in, I guess, and so on and so forth. So we'll do that, and I'll introduce those cases, but we'll finish off today with the video because I think it's a nice natural end. All right, before we launch into that, are there any questions or comments about the assessment process at all? No, we're good?
It's good.
All right, so I'll press play.
Cars, I'm looking at them and going, normal car, normal truck. My biggest fear has to do with an El Camino. When I see an El Camino or hear the word, I have to wipe off the El Camino's bad luck. The longest period of time I spent wiping off the bad luck was close to 10 hours.
Chad's OCD was a big reason why we split up. He's too consumed with himself to care for anyone else. He needs help, and he can't do it alone.
When we do exposures, you're going to feel those symptoms go up and peak, and ultimately it's going to come down without you doing those compulsions.
Sometimes you want to die because you have to keep doing these things over and over again and you can't stop. I've been trapped in this for like 25 years, man. Of my 35 years, I just want to be free. I want to be normal, and I don't want to do this stuff anymore. One, 2, 3, 4, 4, 4. 1, 2, 3, 4, 5, 6, 7, 8, 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. Looking to the south, east. Gotta do it again. 1, 2, 3, 4. When I wake up in the morning, the rituals begin right away, and everything I do is dictated by the OCD. Plug it in, and hopefully I don't think of something bad. If I do, I have to unplug it. Look up, because looking up is good. And then do it again. If I don't do rituals, I feel like bad things will happen. And so a way to prevent the doom or the bad thing, I do the rituals. Northwest, good, very good. Southeast, good, very good. Southwest, really bad. Keys are going that way. The keyboard is usually a little skewed. If I put my phone here, it has to be. These inhalers have to be. The mouse has to be facing northwest, especially the pick, the guitar pick. Otherwise, something bad to the band will happen. Logically, I know that it's a superstition and that the universe doesn't work that way. But on the other side, the OCD brain comes in and says, oh, no, this is real. We got to do this. And it's so compelling, you have to do it. I avoid changing my clothes because I got to put them on over and over again, especially socks. I haven't changed my socks in a long time. 1, 2. I was doing stuff like taking on and off clothes, flicking lights on and off hundreds of times. That's 3 times, so I gotta do it one more time to make it 4. 1, 2. At the age of 16, I was diagnosed with OCD, and after I got treatment the first time, my OCD almost completely disappeared. It was wonderful. It's like enlightenment, but it only lasted until I was about 29, and then it came back, just like the therapist said it would. Yeah, see, those were off while I did that, so I didn't do that one. How come you can't leave your apartment? You said the 20. Well, because at any moment one of those things could drive by. Oh, because El Camino's. Not just for El Caminos. Don't even talk about it, because then I have to do it. The whole El Camino thing started because one day in the car, an El Camino drove by us, and my buddy Russ was like, "You got to wipe that off." And I was like, "What?" He's like, "Wipe off the El Camino or something bad will happen." With someone like me, I take that and just spin it way out of control and it becomes this huge, multifaceted ritual. I have done it for 10 hours straight, and that's the longest I've done it.
Seems like Chad is at one of the more difficult points in his life with the OCD. It's such a big part of his life. I don't know where he's going to end up without treatment or help.
Sorry.
Everything about it breaks my heart.
Every car got to basically check. Is that a normal car? Normal car, good, it's safe. Normal pickup truck, safe.
There's one right there, mother. Holy. See, man? At any point, one of those will drive by.
So full of anxiety, I saw the thing that, damn, I can't even talk about it, or I have to start rubbing again.
Yeah, those things are everywhere. You'd think that no one would drive that anymore.
Yeah, I'm totally soaked with sweat. My heart is beating really fast. You just gotta take deep breaths. It's like you're hyperventilating. Now, see, the thing is I will definitely tonight go back and do my ritual of rubbing it off and facing northwest and looking at the numbers and singing a song in my head that has to be sung all night long. I think I have a lot to offer, but with this stuff, there's nothing. That's completely stupid. It's completely stupid. I'm really angry about it. I can't do anything. I can't stop it. I'd give anything to be free from it, man. I think I'm completely crazy. It doesn't stop. It's not my fault.
Okay, what do we think?
It really left him no room for life. He wasn't able to do anything. The OCD part of him completely took over.
Mm-hmm.
It's so sad and distressing to watch, even just watching.
Yeah. And that's what it's like in an extreme form. That's how intense it gets. But as that show progresses, he ends up doing really well and responds really well to treatment, and is able to reduce quite a lot of his compulsions and re-engage in life, which is good. So it's a happy ending. True American TV show style.
Yeah. Celine, is it a good outcome, like if he'd responded to that, because he'd had a positive response to previous intervention?
Yes, absolutely. Yeah, definitely. It's a good predictor for sure of future what do you call it? Outcomes. Yeah. All right. Thank you so much for staying for the whole 2 hours. It was a long session. But I'm hoping the rest won't be as long. But you know, we'll take what we need in terms of managing questions and all the rest of it. But I hope that this part of it was informative in terms of helping with the assessment process. The rest of it will be a lot more practical and much more focused on treatment in terms of psycho-ed and how to actually structure it, building hierarchies and doing all the rest of it too. So yeah, we'll get stuck right into it. So for next week, we'll be fine. Did the initial email that you guys got when you signed up, did that give you the link for all 4 weeks? All 4 meetings?
I don't think so. I think it was just the one.
Just the one? Okay, well, I'll send around the link for next week with the with all the information for that, the content and all the rest of it as well. Just like I did for this week's one. So I'll do it a couple of days beforehand. So you'll have a couple of days to go through it. Okay. Thank you all so much for coming on today, and I will see you all next week.
Thank you.
Thank you.
Good night.
Bye.
Bye.
Oh.
I think we got a